So good morning, good afternoon and good evening. It's my pleasure to open the meeting this morning because John is on vacation, a well-deserved vacation. And before I make what I think is John's comments, which is reviewing the housekeeping, I just want to thank most sincerely Ashley Patrick, who has managed within a few minutes to make sure that we're up and running, managed any of the complicating irregularities that I probably created. So thank you, Ashley, for being here and making sure that we're on time and we've kicked off. So in John's place, I'm going to briefly review housekeeping, and then I've got the pleasure of introducing our expert speaker. So John would be saying, well, we'll begin this virtual cafe with opening remarks, and this will be followed by a moderated question and answer session. Please use the chat function along the bottom of your screen to indicate that you may have a question or comment, and I will call on you to pose the question during the moderated discussion. And please use the chat box if you've got any resources as well, because that's always important to exchange knowledge. The virtual cafe is recorded and streamed live on the IFA Facebook page. You know, the video recording and resources are made available every week on IFA's website, and you will each receive a follow-up email with these resources and an invitation to the next virtual cafe. The cafe today we're talking about hearing and hearing in later life. And I have the great pleasure of introducing Dr. Dalia Tsimpida, a postdoctoral researcher based at the University of Manchester in the United Kingdom. You know, Dalia and I had a great conversation last week, and it was engaging and inspirational from many different perspectives. And, you know, part of it is her personal commitment to this field. Dalia has an extensive background in hearing health in later life, health psychology, social epidemiology, health policy, and health services planning, and vast experience in delivering innovative research on lifestyle factors with hearing loss in older adults. Her research has led to the foundation of a new and distinct emerging research field called hearing health inequalities. In 2020, she received the International Society of Audiology Scholarship for her pioneering research findings on the prevention and early detection of hearing loss in primary care and its potential in maximising the opportunity for healthy and active ageing. It's a great honour that you're with us today, Dr. Dalia Tsimpida, and the floor is yours. Thank you.
Thank you very much, Jane, for the invitation and for such a nice introduction as well. I remember when we first met, you said that my research is important, but my passion to make a difference with my research is even more important. And this is, in my opinion, one of the greatest compliments a researcher may ever hear. So thank you very much again. I'm truly honored to be here today with people from all over the world. I'm based in the Institute for Health Policy and Organisation at the University of Manchester, UK. But my educational and career journey was not linear at all. I have an interdisciplinary background in health psychology, audiology, health policy, health services research, and advanced methodological skills in epidemiology, mapping, spatial, and big data analytics. But 20 years ago, my first job was in the military, where I worked as an aircraft weapon technician. This is probably an occupation with the highest possible level of occupational noise exposure. And it was then I started noticing that many of my colleagues did not use ear protections to protect their hearing. And I noticed a bizarre thing that in many occasions, hearing loss was considered a marker of achievement, a sign of many years of experience in the occupation. And I was studying that time for a degree in psychology in parallel to my full-time job. And I was able to look into this matter through different lenses. And start thinking that hearing loss is not and cannot be an inevitable consequence of getting older. We were 22, 23 years old, and many of my colleagues had already moderate high frequency hearing loss, which is traditionally been linked with aging. After my degree in psychology, I attended classes to learn the Greek Sign Language and deaf communication. This is a course, a national certification that takes 4 or 5 years to be completed. So during that period, I met many people. I gradually became a hearing member of the deaf community in Greece. And I saw firsthand, seeing my friends, my deaf friends, having so many barriers in access to health services and in the use of health services, difficulties in communication with health providers, and in doing simple things that the hearing people take for granted. For example, I was shocked one time when I saw my friend that missed her appointment because she had not heard her name being called in the waiting room while she was there for the appointment. So being also motivated and having a personal reason to be involved in this field, as 2 members of my family lived with hearing loss, I decided that I wanted to investigate further these issues and understand these barriers and find solutions. And so I advanced my studies in a master's level in health policy and health services planning, where I completed a project. The first project in Greece investigated the health-related quality of life of deaf and hard of hearing people, and the issues, the barriers in the access and use of health services. After my master's, I was honored to be awarded a full studentship to do a PhD at the University of Manchester. So I made a career move from my position as a senior research psychologist in the Hellenic Ministry of National Defence, and I moved to the UK to complete my doctoral studies. So I'm going to talk to you today about an important part of everybody's life, about hearing. Hearing is important because hearing connects us. We humans are made for relationship, and hearing, for those not natively deaf and fluent in sign language, is central to the sharing of emotions and ideas and happenings. In the next 15 minutes, I will present how my research challenges the current scientific thinking in hearing loss research and why making hearing care for all a public health priority will maximize the opportunity for healthy and active aging. Hearing loss, you may already know, is far beyond a sensory disorder. Hearing loss may affect the mental well-being, the interpersonal relationships, and the whole participation of people in society. When somebody loses their hearing, it is not only the ear function itself that is affected, but many related activities. For example, the speech comprehension in a conversation and the full participation in society. For example, the employment opportunities are limited. People with hearing loss face many barriers in education, in attending social events like this today, and receiving health services. During my PhD, I presented the first study that examined the association of objectively measured hearing loss in older adults in England with 4 different socioeconomic position indicators: education, occupation, income, and wealth, and several modifiable lifestyle factors such as a high body mass index, physical inactivity, tobacco consumption, and alcohol intake above the low risk level guidelines, which is defined as 14 units of alcohol per week. I used data from the English Longitudinal Study of Aging, or ELSA. The ELSA is a large representative dataset with information on the health, social, well-being, and economic circumstances of the English population aged 50 years old and above. This dataset provides a unique resource for exploring issues associated with aging in England in 21st century. The study is funded jointly by UK government departments and the National Institute on Aging in the USA. What I found? The study showed that the hearing loss among older adults is as strongly associated with socioeconomic and lifestyle factors as with core established demographic risk factors such as age and gender. In simple words, age was not the most important risk factor for what is widely known as age-related hearing loss. Instead, several preventable, modifiable factors were involved to a large extent in the pathways of the association between socioeconomic position and hearing loss. It seems, therefore, that the way that people live their lives significantly affects their hearing health outcome. If it didn't, and only age was responsible for the loss of hearing as we grow old, we would expect that the prevalence of hearing loss in people of the same age would be the same no matter where they live. In order to test that assumption, I analyzed all the available data in the English Longitudinal Study of Aging, or ELSA. This is waves of collection of nearly 75,000 person years, because it's a cohort study, spanning a period of 16 years, from 2002 to 2017. That study was the first ever to investigate geographical patterns and trends of hearing loss based on a representative sample of older adults and not through population age projections, which is the current way we estimate the hearing loss prevalence, through the age projections. I will share now my screen to show you the maps with the surprising results. So we found that the number of people with a hearing loss increased by 10% over 15 years. However, the mean age of the people I analyzed stayed the same. This is due to the sampling method in ELSA. You can easily look at the different colors that represent the differences in hearing loss prevalence derived from people that have similar age profiles in each region and in each year of collection. Over the same period, from 2002 to 2017, the samples had markedly different hearing outcomes in terms of where respondents lived, and the increased rate of hearing loss ranged from 3.2% to 45% between regions of England. Remember, these representative samples were from people with similar age profiles. Deprivation, manual occupations, and alcohol misuse related to hearing loss were much more prevalent in the north, suggesting a possible hearing north-south divide, which was previously unknown. These results provided surprising evidence that the increasing trend in hearing loss prevalence was not age-related as widely believed, but potentially due to social and lifestyle changes over time. This is a significant milestone in hearing loss research and a breakthrough that gives us considerable insights into what is actually happening. It seems, therefore, that the way people live their lives significantly affects the hearing outcomes. These findings are supportive of a new conceptualization in hearing loss, which argues that hearing loss is not a natural consequence of getting older, an inevitable accompaniment of aging, but a preventable lifestyle disease as it's linked to environment and lifestyle. We need to consider two things at this stage. Nearly 1 in 3 people over 70 years old do not develop high-frequency hearing loss, a condition that has traditionally been linked with aging. And second, what is widely known as age-related hearing loss has similar characteristics to sensorineural hearing loss that can occur at any age. Despite diligent research over the past decades, the scientific understanding of age-related hearing loss is very limited. So I'm wondering, what does age-related hearing loss actually mean if the increase in hearing loss is not related to people's age? The term age-related hearing loss is not an inclusive term to express the many hearing problems without a specific etiology in older age. So I and my colleagues recently proposed to the scientific community a new term, lifestyle-related hearing loss, where lifestyle refers to social practices and ways of living adopted by individuals that reflect personal, group, and socioeconomic identities. So hearing loss seems that is closely linked to the way that people live their lives. Hearing loss nearly always develops gradually. It is a non-communicable disease with slow duration and slow progression, low duration and slow progression, and people don't see it as a dramatic health problem requiring urgent intervention. They just have labeled this as something that is more likely to affect the elderly, and they don't do nothing before they are too old. People persevere with declining hearing for about 10 years, according to the evidence, before they seek help and uptake a hearing aid. Findings from a recent study that I published in JAMA Network Open showed that up to a third of older adults with hearing loss in England could be undetected and untreated. Importantly, the study showed that those belonging to high-risk groups are most likely to remain unrecognized, such as people who face socioeconomic inequalities and adopt an unhealthy lifestyle, because this factor may affect the initiation of help seeking for hearing problems and consequently the referral from primary care to ear specialists. So what is the impact of hearing loss on healthy aging? Historically, hearing loss has been conceptualized as an impairment and has been managed within a biomedical model of care and managed clinically within an isolated model with little consideration of comorbidities. In my recent project, I found that hearing loss is linked to depression, causes depression. This was a causal mechanism in the longitudinal study of aging. This study is now under review for publication and is soon to be published. I saw that across different socioeconomic groups, there was a graded relationship with those in the lowest socioeconomic position, that is the 20% poorest part of society, had up to double the relative risk of depression compared to those in the highest wealth quintile, the 20% richest part of the society. So we can see that those in a lower socioeconomic position and belonging to high-risk groups are up to 2 times more likely to develop hearing loss, are more likely to remain undetected and untreated, and are up to 2 times more likely to develop depression due to hearing loss. Unfortunately, hearing loss is also linked not only with depression, but with many other conditions. As you may already know, it is the highest modifiable risk factor for dementia, and is also linked with cardiovascular disease, diabetes, chronic kidney disease, is tied to threefold risk of falling in older adults, with 32% increased hospitalization and greater risk of mortality. Not only due to the comorbidities that come with or due to hearing loss, we have also another problem here. Hearing loss affects communication in healthcare settings, so affects the whole quality of care and the management of all conditions that are commonly comorbid with hearing loss. People with hearing loss often find it really difficult to communicate with health providers, and very often they left unclear about their conditions or the medical instructions after the appointment. This is crucial not only for them as patients, but also for the healthcare professionals, so as to be able to communicate with the patient, to understand, to ask about symptoms, to have a conversation with the patient, and to be able to do an accurate diagnosis. The problems with communication I have found in the previous research that are associated with poor adherence to medical treatment, which poses a significant risk in patient safety, especially in polypharmacy, which is a common issue in older adults. So we can see that hearing loss poses a significant risk to functional ability that enables well-being in older age and dramatically affects people's opportunities for healthy and active aging. We can now understand why hearing loss may act as an accelerator of aging, especially for those belonging in low socioeconomic position. The time is now to implement the notion of the first ever World Report of Hearing and make hearing care for all a public health priority and let people enjoy longer and healthier lives. Thank you very much for listening. I'm happy to answer any question you may have.
Look, thank you very much, Dalia. That was, not only informative, but it also starts aligning, with other presentations in the work of IFA, around inequity, and we go back to that profound statement that Dr. Tedros made earlier in the pandemic: the poorest of the poor will pay the highest price when it comes to healthcare. And it's not poor in terms of the economics, it really is, that when we talk about, inequities, it's rooted in, where we're born, the levels of education, the environment in which we live in. So all of these factors, some of which are modifiable, but some of which, that we must create the policies that enable a person, to have access to, the most reasonable screening, prevention, and treatments. I have a question, and then I'm going to ask Eileen from Ireland to come forward. We've been doing a lot of work around vision and, poor adherence. And I have to tell you that if I go back to the survey that's going out to many countries, there isn't a question around hearing and adherence to treatment procedures. So have you done any work, or what are your thoughts about how the adherence due to hearing loss is impacted, or how is adherence to management impacted by hearing loss?
Yes, thank you very much. This is a very interesting question. What I've done in my previous project is to examine the health literacy of specific population groups. You said it is very correct that where people live is something that is affected by the wider determinants of health, and people cannot choose where they will be born. But we need to remember that according to the WHO, over 50% of cases of hearing loss are preventable, and people can do many things in everyday life in order to improve their quality of life. The concept of health literacy refers to one's ability to make judgments and decisions concerning healthcare, disease prevention, and health promotion. So we have a factor of specific population groups that have health literacy limitations, which is reflected to the higher prevalence of hearing loss. These groups develop hearing loss because they are usually in lower level occupations, which are the occupations that have exposure to high noise. So this is one factor. And the other issue is that when somebody loses their hearing, the important thing that is affected is the communication. What is the problem is that many people think that hearing loss refers only to the inability to hear sounds in terms of the intensity of a sound in decibel. But hearing loss refers not only to the intensity of a sound, but also to the frequency of the sound in hertz. And what is happening, and people don't realize due to health literacy limitations, is that when you have a hearing loss of only certain frequencies, it is harder to detect yourself because the frequencies unaffected appear pure and clear. In adherence, I have seen a quote saying that the fact that 15 and 50 sound the same is something that everybody is aware of, but no one is acknowledging. So imagine that a person that has unacknowledged hearing loss and has misinterpreted the guidance of 15 or 50 that a doctor has said to them about a medication, for example. So this is a very multifactorial problem, and many interventions need to be done in the areas of health literacy, which refers to people's ability to protect their health during their life course.
Look, thank you for that. And I'm going to move on because we've got 3 more questions. So I'd like to ask Eileen, and then Mark, you've made a comment, and then Joan Kavanagh. So Eileen from Ireland.
Thank you very much for this discussion. Where I'm coming from, I liked your term lifestyle hearing loss and lifestyle. I recently heard about lifestyle myopia, and it relates to public policy in mainly Japan, Singapore, Taiwan, and Australia for young children. And they've taken a national intervention strategy on that. But we're all looking here, where I'm coming from is on the use of electronic devices and headsets and all sorts of feedback coming along through our ears at different frequencies that are disorientating a lot of people. So has there been any research on recently of the impact of all of these technologies on our ears, especially if you don't have any filters in any headsets?
Thank you very much, Eileen, for your question. Unfortunately, to my knowledge, there has not been any research specifically on this topic, which is very important. The reason is that the current scientific thinking has pointed to older age as the main cause of hearing loss. So this is, for example, the problem I spoke in a previous talk. We can't improve what we don't measure. Currently, any hearing loss after a specific age is labeled as age-related hearing loss, and we don't do nothing for this. Even in the hearing loss prevalence estimates, we, not only in the UK, but globally, we calculated the estimates based on population demographics. So at this stage, the scientific thinking has primarily focused on the age-related hearing loss, which is wrong in my opinion, because we ignore so many other causes, as you mentioned, during the life course, due to environment, due to the climate, possibly. This is something I aim to explore in the future. Due to the lifestyle, so many modifiable factors, alcohol, smoking, physical activity. So there are so many areas we need to explore and not just accept that hearing loss comes inevitably with older age, and we just start thinking that after the age of 50, we need to motivate people to seek help and uptake a hearing aid. At the moment, 1.1 billion young people, according to the World Health Organization, are at risk for hearing loss due to unsafe use of portable music devices. And we just start doing things and intervention for this. We should not wait until those people become 50 years old to label them as having age-related hearing loss and start thinking what are we going to do with them in order to achieve healthy aging.
We've got 5 more questions, Dalia, so I'll skip along. So Mark, Joan, and then Amara. Mark, and I think we'll take those questions and then we'll come back to you, Dalia. Mm-hmm. Mark?
Yes, mine really wasn't a question, except that my mother had dementia coming on, as well as her hearing loss. So I used to take her to the doctor visits because she couldn't remember or hear what the doctor was telling her. So there was a difference between understanding whether she had the hearing loss problem. We didn't even detect it was dementia coming on, right? So
right.
The communication piece was really important for me to be there.
Yeah, look, thank you for that. Joan and then Amara.
Hi everybody, Joan Claverton from Galway in Ireland. We have a group, Active Retirement, who would meet every week. This is before COVID, of course. And we noticed that some people were talking during a presentation and whispering. And when you would ask them, you know, can you not hear with your hearing aid? No, they left the hearing aid at home. Some of them seem to be embarrassed about wearing a hearing aid. The other thing is, it does, they say the background noise affects the hearing aid. And what we have found, and I have found it personally in playing golf, we would go in after the game of golf for coffee, which is a big social aspect of the game. But this particular person couldn't go in because she wouldn't be able to hear with all the chatter inside. It affects the hearing aid. So I just wanted to ask Dalia, you know, what she has found about people wearing hearing aids or not wearing them.
Okay, thank you. And last question, Amara.
May I answer this?
Oh, sure. Yes.
Yeah.
We've got a few to get through, Dalia.
Yeah, thank you very much, John. This is a really crucial point here. And thank you very much for this up in the discussion.
Amara, just hold the question for a moment. Dalia's just responding to Joan Kavanagh's question.
Okay.
All right, sorry.
So about embarrassment, the misconception I'm bringing up about the hearing loss that is linked with aging is, in my opinion, the reason of this problem. People feel embarrassed to wear a hearing aid because they don't want to be considered old. Doing a hearing aid, doing a hearing test early in life, for many people is like doing a test for aging. So this is why they avoid to seek help and uptake a hearing aid. In my research that is published in JAMA Network Open, I will add this in the resources to read that afterwards. I found that people with objectively identified hearing loss, they had hearing loss, and they responded in the self-reported questionnaires that their hearing is normal. They can hear normally. So this shows that people are reluctant to accept their hearing because they don't want to be considered old. This is the reason that hearing aid brings stigma. So changing the whole approach and the linking hearing to something that has been labeled only to affect old people is, in my opinion, the important point in order to improve population's health. And regarding the background noise you mentioned, hearing aid do not restore hearing. They just amplify the frequencies that the brain is still able to process. So trying to preserve this ability, this natural ability, and to take care of our hearing earlier in life will improve our hearing ability throughout our lifespan. It is something that we cannot do, just wait until we are old and to be considered that this is age-related hearing loss, and then after waiting 10 years to seek help and obtain a hearing aid, to still keep wondering why we cannot hear. We cannot hear because the frequencies that have left active are not enough in order to overcome the masking sound from the background noise. Our brain has lost the ability to work in these frequencies. So this is why it is important to delink hearing loss with older age.
So we've got 3 questions about lifestyle. So I'm going to ask the people to give you the questions and then you can talk about lifestyle. So Amara, Juta, and Linda. So Amara.
Thank you very much. So the lifestyle, I think you've been able to put some context to them, alcohol and the rest. So maybe by the time you respond to the others, we can get that. But another thrust of my question is on strategies that have worked. Whatever I hear from this meeting, I want to put it into actions. So I wouldn't know from the course of your studies if there are intervention or studies, especially prevention and promotion, that has worked, and at which age group would it be preferred to start some of those lifestyle modifications, that will prevent hearing loss by the time the person gets older. Thank you very much.
Thanks, Samara. Jutta, and then Linda, and then we'll go back to Dalia.
Yeah. May I answer to Amara first, or?
They're all about lifestyle, and I'm
okay.
concerned that we're going to run out of time. So Jutta and then Linda.
Okay, hi, thank you. My name is Jutta. I'm beaming in from Toronto, Canada. Yeah, I was interested in the steep rise or the rise in lifestyle related hearing loss. Was wondering what are the major factors and according to what Amara was saying, the main reason for the question is how can we prevent it earlier? In terms of myself, I noticed I'm 61 now, and I noticed my hearing is declining. And I noticed that my hearing was declining. I thought that certain sounds I couldn't hear when I was much younger. I've had 2 hearing tests, but I was always told everything is fine. Thank you.
Thank you. And last one, Linda Parton.
Hello. As you know, I'm not an academic, but in another part of my life, I'm involved with a project around stigmatization. And this week we were looking at unintended stigmatization that's come out of public health messages. So I'm wondering if you're going to change, if the focus is going to change on onto lifestyle factors, how do you avoid the danger of stigmatizing people with a hearing loss? Yeah, are you going to be saying to them, you've not lived in a good way? Such as people of experience with lung cancer who've never smoked, or people with type 2 diabetes might feel that it's their fault.
Thank you. They're great questions. Back to you, Dalia.
Thank you very much all for these very interesting questions. Well, I will answer in a reverse order, starting with Linda. It is important to break the stigma around age-related hearing loss, because this is also a factor of ageism. People feel that if they have hearing loss, they are old, very old. In terms of people that are young and have hearing loss, they need to understand that this is not something that makes them become old. So they need to seek help and obtain a colorful hearing aid and be proud of this in order to protect their whole quality of life and the employment opportunities and the social participation in society. There are a lot of interventions that we can do to not stigmatize people that have already hearing loss. This is something that, of course, there are some genetic factors. There are factors that people could not avoid, but we need to remember that further to the wider determinants of health, there are so many things that people can do in their everyday life to decrease the volume in their device, to wear ear protection in the clubs, so to bring awareness. For people that have already hearing loss, we need to help them understand that they can still do things to improve their life. For example, to participate in programs to have a physical, to increase their physical activity that will improve their participation, and this will decrease their depressive symptoms that come due to hearing loss. So I think that there are many interventions that can be done. And if people know that, for example, that alcohol misuse can harm more their hearing, they may adopt more healthy behaviors in the future. Regarding the perception of health professionals, the misconception that the hearing loss comes naturally as we grow old has made many health professionals believe that they should not refer people with hearing problems if they are young. If a patient makes a complaint that they don't hear very well, they may think that no, you're very young, you don't have any problem, there's no reason to seek help for that or obtain they cannot estimate that at this point in primary care, but we don't have screening programs. And this is a reason that we need to bring screening programs to have early identification of hearing loss issues, no matter the age of people. And in terms of interventions, I have recently published the conceptual model for hearing health inequalities that offers a visual representation of the many modifiable risk factors across the lifespan, and offers an instrumental tool that echoes the sentiments of the World Report of Hearing, and offers solutions in distinct life stages. I propose several interventions that can tackle hearing health inequalities in 3 levels: mitigation, prevention, and undoing inequalities. Mitigation is to reduce the impact of social inequalities that already exist. For example, in general practice appointments, the service providers need to be aware that patients cannot hear well, so they need to provide the instructions in a more accessible way. In order to prevent inequalities, this involves acknowledging those who have limited access to hearing health and whose working and living conditions put them more at risk of suffering from poor hearing. Several primary prevention activities can be done, such as improved care, universal vaccination programs, and many interventions that are described in the World Report of Hearing can be implemented even in low and medium income countries to reduce the incidence of hearing loss from preconception to adulthood. In addition, secondary and tertiary prevention activities, such as prompt intervention, fitting of hearing devices, and training in sign language are important and should be actively encouraged. And finally, undoing hearing health inequalities. I mentioned that health inequalities impact people that that are in a lower socioeconomic position. So differential economic policies that aim to decrease the wealth gap will be beneficial. There is the healthy aging challenge at this moment in the UK. The healthy aging, the decade for healthy aging has just started, and the governments aim to ensure that people can enjoy at least 5 extra healthy, independent years of life by 2035, while narrowing the gap between the richest and the poorest. So making hearing care for all a public health priority will decrease this gap between the richest and the poorest in society.
So look, thank you, Dalia. And just for your information and those on the Global Cafe today, you know, Onda Stanku, IFA Program Manager, is leading the pre-conference convention on hearing in later life on the 9th of November, you know, as part of our global conference. So we have 2 final questions, Agnieszka and Meg. So Agnieszka and then Meg, and then over to you, Dalia.
Thank you very much. Can you hear me well?
Perfectly, thank you.
Okay, thank you, Dalia, for your presentation. You have practically addressed most of what I asked about, namely why people seek help late, and is this due to socio-psychological issues? But I was wondering whether you'd agree with the fact that younger and younger people are suffering from hearing loss these days, and might this paradoxically contribute to removing the stigma that is stereotypically guided by that idea that hearing loss comes with age? Perhaps just as young people don't have a problem with wearing glasses, they more and more increasingly would have no problem with the hearing aids being visible on the ears?
Okay, I'll just go on to, thank you, that's a really interesting question, Agnieszka. I'll just go on to Meg, because I think it's a great question to finish off. So Meg, would you like to pose your question?
Yes, good morning. I have observed that older men tend to lose their hearing, or at least they lose the higher frequencies. I happen to live with one of these people, and so who has just gotten a hearing aid. So we're living through this as we speak, but I just wondered if gender doesn't play a factor.
Thank you very much, Meg. Back to you, Dalia.
Thank you very much. First, let's explain why we need to break this stigma. We should not wait until this young population 30 years later has hearing loss in such big numbers that we will not be able to achieve healthy and active aging for a large part of the population. We need to reverse this misconception as early as possible. And in order to improve hearing health, we need first to recalculate the prevalence of hearing loss. In a last paper I've published, I will include that in the resources. I highlight that the way we currently estimate the prevalence of hearing loss is basically wrong, because we have not taken into account the many cases of people due to environmental and lifestyle factors. We don't measure them, and we just calculate the estimates according to age demographics. So this brings us back to the misconception that we talk about age-led hearing loss and what we are going to do about aging. So this is not about that. We should recalculate the estimates and adopt a socio-spatial approach in planning sustainable models of hearing care based on the actual population needs and not on age demographics. As you saw in the maps, there are many differences in people's hearing health, and people have worse hearing health at an earlier age if they live in an area with high deprivation, if they work in manual occupations and adopt an unhealthy lifestyle. So this needs a discussion on how we are going to implement a different health policy approach, not only in the UK, but globally, because at the moment, the estimates are based on 53 epidemiological studies from 31 countries, and only 3 of them have analyzed data from nationally representative samples. So the uncomfortable truth is that we currently ignore the magnitude of the problem. And this is important to have robust hearing data because we need accurate cost analysis. The current figures are based on a prevalence-based costing model that may underestimate the global economic cost and the cost effectiveness of intervention. Unaddressed hearing loss is estimated by the WHO that poses an annual global cost of $750 billion. This is only by taking into account the older population, because the current thinking points to the fact that we talk about mainly age-related hearing loss. So I estimate that this is even higher than $750 billion annually, because we need to take into account the lifestyle factors and the population during the life course, which is currently unrecognized and untreated.
Dalia, we're coming up to the hour, so we need to be wrapping up, I'm sorry to say. So if you can just touch on the response to Meg about gender, that would be really helpful.
Yeah, also in a paper that we'll include in the resources, you can see that the current thinking about the gender, the male sex as a risk factor is also can also be challenged, because I found that this is linked to men in my study had increased hearing loss due to high body mass index, physical inactivity, higher tobacco consumption, and higher alcohol intake above the low risk level guidelines. So if we adjust for these factors, we see that the decrease in hearing loss is the same for both genders, which paves the way for many interventions that can improve population's health in both genders. And also this is also a fact about toxic masculinity. I mentioned in the military where I was worked, people want to be considered brave, that can live over the limits, that don't have problem to be exposed in high noise. So this brings also several sociological issues about the genders.
Okay, thank you very much. Wow, what a jam-packed hour we've had with you at this Global Cafe. I'm just going to just introduce the speaker for next week, and then I'll come back to you, Dalia, to ask for your closing messages. So it will be with great pleasure that we're in conversation with Julia Wadu next week, next Friday at 7 a.m. Eastern Standard Time. You know, she is one of the experts in advocacy and engagement in creating an age-friendly world, and she is from Age Platform Europe. So please don't miss that. And of course, we have our global conference coming up on the 9th to the 12th of November this year, and it will be in person as well as virtual. So please follow that on our conference website. And just in closing, I want to once again thank Ashni Patrick for your stellar job in helping this Global Cafe even happen today. So thanks, Ashni. And Dalia, you've been inspirational to us. You said something right at the outset that captured my attention, and it was, hearing is the basis of relationships. And I think that that is the heart of the conversation that we've had today and these global cafes. You know, we are in relation with each other in our life's journey. So thank you very much. I leave the floor to you so that you can provide us with some takeaway messages. Thank you very much.
Thank you very much again. Well, I will close with 3 take-home messages. First, lifestyle and not age-related hearing loss. Our focus regarding hearing loss should not simply be on the age of older adults, but on factors earlier in life which impact on people, and if modified, could reduce hearing loss in older age. Second, we can't improve what we don't measure. We need a socio-spatial approach in planning sustainable models of hearing care based on the actual needs of the population and not on age demographics. This might offer a viable opportunity to catch the problem earlier and let people enjoy healthier and longer lives. In the new evidence, regular assessment of the extent and the causality of the population's different audiological needs within the countries is strongly supported. And third, the importance of the life course approach. Hearing loss poses a significant risk to the functional ability that enables well-being in older age and dramatically affects people's opportunities for a healthy and active aging. Therefore, improvement in hearing loss outcomes during the life course will result in improvement in the overall people's physical, mental, and social well-being, maximizing the opportunity for a healthy and active aging. As you know, healthy aging can not only add years to life, but also adds life to years. and healthy hearing plays an important role in that. The first ever World Report on Hearing echoes this sentiment, and the time is now to make hearing health for all a public health priority, and most importantly, to let people enjoy healthier lives. Thank you very much.
And Dr. Dalia Tsimpida, thank you very much for being our expert speaker on the IFA Global Cafe. All the best, stay safe, stay well, and thank you for your leadership in this particularly important area. Thank you.
Thank you.